In this video, we will discuss the differential diagnosis for the lytic skull lesions. We will discuss about the parietal foramina. We will discuss regarding the Wormian bones and the differential diagnosis or the causative factor or the associated factors for the Wormian bones. And the last we will discuss about the differences between the dermoid and the epidermoid cyst. So firstly, we will start with the lytic skull lesions. So in the children's, the differential diagnosis for the lytic skull lesions are first one is the Langerhans histiocytosis. Second one is the epidermoid cyst. Third is the some kind of infection, and the fourth one is the some mets. So these are the common kinds of the etiology which can lead to the lytic appearance. So firstly, we will discuss Langerhans histiocytosis. Basically, it is the invasion of the dendritic cells which leads to lytic appearance on the CT scan or in the advanced cases on the X-ray. So basically, the first point need to remember is that there is the no sclerosis surrounding the margin of lesion, while in the epidermoid cyst the margins will have some sclerotic appearance. So this is the keyword used to differentiate the Langerhans histiocytosis and the epidermoid. So the next point in the Langerhans histiocytosis is the button sequestrum. That is, it produces a sequestrum of the intact bone. So keyword is button sequestrum and no sclerosis surround the lesion. That is the important point. So by this we can differentiate the Langerhans histiocytic lesion versus epidermoid cyst. And the other are the infections or the metastasis which can be differentiated on the basis of the clinical history or the further contrast studies. Next is the parietal foramina. It happens because of defective or incomplete ossification. They are a benign defects. So if they are less than 5 mm, then they will be termed as the parietal foramina, and if it is more than 5 mm, then we should suspect about some venous developmental anomalies underneath it. So by the size of the defect we can differentiate or we can further evaluate. Next is the Wormian bones. So Wormian bones are the basically intrasutural bones. They are the multiple bones located around the lambdoid suture. So they are basically located around the lambdoid sutures. Now about the differential diagnosis is, if these intrasutural bones are less than 10 in numbers, then they are idiopathic. If they are more than 10 in numbers, then it is associated with osteogenesis imperfecta. And if they are more than 10 in number and associated with absent clavicle, then we should suspect the cleidocranial dysostosis. So by the numbers we can differentiate them or can rule out the etiology. Other differential diagnosis for the vermian bones are: one is the pycnodysostoses, in which there is the defective ossifications. One is the osteogenesis imperfecta, as we already discussed. One is the rickets, which is the vitamin D deficiency. And the next is the cleidocranial dysostosis. Then there is the hypothyroidism, or the hypophosphatasia can also cause it. And one is the acroosteolysis, in which there is the erosion of the bones on the tip of fingers. So these are the associations with the vermian bones. Now the next will be the dermoid versus epidermoid. So to differentiate them, first is the age factor. This epidermoid is usually present on the late age, that is around 20 to 40, while the dermoid present at the early age. In the epidermoid, usually the skin is only involved, while in the dermoid, along with the skin, there are also involvement of the follicles or the sweat glands can happen. Next point is the location. The dermoid is always located in the midline, while epidermoid is located in the side of the skull, not in the midline. Next is the appearance on the MRI. As the dermoid is involving the fat components, so usually the dermoid will appear hyper intense on T1 and T2. While the epidermoid will have the appearance of hypointense on the T1 or variable appearance, while hyper on the T2. And also there is the diffusion restriction on the epidermoid. That is a key point. The wall will enhance in the dermoid. Similarly, the calcifications will be there in the dermoid. And these dermoids can be associated with some kinds of encephalocele. So these are the basic key points by which we can differentiate or can reach to the diagnosis in these lesions.